Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for tuning in to my latest video. This patient attended with bilateral impacted earwax and dead skin due to the misuse of Q-tips and cotton, or what we refer to in the UK, a cotton bud. Starting off with the right ear, the patient did advise that he also suffers from recurrent ear infections, so chronic ear infections of the ear canal known as otitis externa. And when we pull the endoscope out of the ear, just as we did there, the entrance, the concha bowl, so the external part of the ear, the bowl itself, we call that the concha, and more specifically that region, the cavern concha. You can see it's quite red, inflamed, and some sore marks the patient had been scratching there. So this impacted dead skin earwax is right over the eardrum, so we're on the medial bony portion of the ear canal. This part is very sensitive, extremely sensitive, so it's imperative that we avoid contact wherever possible with the bony part of the ear canal, because that can be excruciatingly painful for the patient. You can see we're just very delicately, with a steady hand, trying to peel this dead skin and wax off the bony part of the ear canal wall and also the eardrum. Now with this right ear, the eardrum itself is actually featureless. It's very difficult to visualize the various landmarks we typically associate with a healthy eardrum. So the eardrum is generally, in a healthy eardrum, a slightly blue tinge, whereas the ear canal is quite pink. And you'll see there is a slight, very weak blue tinge. I wouldn't say it's prominent on the anterior portion of the eardrum, which is the front part, and you'll see that in a moment. But it's very hard in this patient's right ear to distinguish and separate between the ear canal and the eardrum itself. It's very difficult to visualize the hammer bone, the handle of malleus, which you can normally see with someone with a healthy eardrum. A normal eardrum is also slightly translucent, so we can see some of the structures beyond the eardrum in the middle ear. Sometimes we can even see the anvil, so the incus, the second of the three middle ear bones. With a healthy eardrum, we also typically get a light reflex. So the torch that we use, so in this case we're using the endoscope, they all have a light source so we can illuminate the ear. The light reflects off a healthy eardrum, and we can see that reflection actually on the eardrum. We call that a light reflex. So when someone's got an absent light reflex, it doesn't always mean that the patient's got a problem with their ear and they're suffering from hearing loss, but the presence of a light reflex more often than not suggests a healthy eardrum and a middle ear. So we're just trying to work in the anterior recess, and you can see I've bent the fine end tip. So we've got a fine end, we always use a fine end tip, which is a less powerful, thinner, more precise suction probe, which we attach to the standard Zollner suction probe. So the standard Zollner suction probe, the lumen its side, it's 2 millimeters in diameter. The fine end that we use, size 18, that is 1.227 millimeters, I believe. So you can see there's the eardrum, and it's very difficult to distinguish. This is some dead keratin inferiorly, so at the bottom of the eardrum. And the reason why this patient has got a featureless eardrum, they've been suffering from chronic ear infections over many, many years. And the outer lateral layer of the eardrum, so the eardrum is made up of 3 membranes. The most outer layer that's facing us, it's the same skin that lines the bony part of the ear canal. So it's a very thin layer of keratin, approximately 0.1 millimeters in thickness. And that skin, if you're suffering from chronic infections, gets inflamed. The fibrous layer as well, so the middle layer, can also get inflamed. In extreme cases, people who suffer from chronic ear infections, acute otitis externa, can also develop a false fundus, which is the appearance of a second false eardrum. And when you look in the ear canal, it's like the eardrum's right in front of you. So the eardrum is typically 3 centimeters away from the entrance of the ear. With a false fundus, when you look in the ear, it just appears as though the eardrum's a centimetre into the ear canal, and that's a false fundus. So this patient doesn't have a false fundus per se, but as I say, the eardrum is very featureless. The procedure is actually done. We could leave it like this. I've seen some comments in the last two videos, but there's a bit of wax here and a bit of wax there that I haven't performed the procedure. The procedure is complete when the sound can reach the eardrum, and typically when we perform earwax removal. So the procedure was complete actually a few minutes ago, but with cases of dry skin, which can develop into otitis externa, I like to remove as much debris as possible. You can just about see the lateral process of the handle of malleus. So the hammer bone itself, the first bone at the top, there's a little pointed bit, we call that the lateral process, and the lateral process is just about visible on this eardrum. It'll come into view in a moment. It's just at the top of the eardrum, it's just about visible. So I'm happy with what we've done near the eardrum. I've removed a lot of little dead skin flakes. So this dead skin, if it doesn't migrate, it can get damp and wet and moist and then lead to an outer ear infection, otitis externa. The patient is on treatment for chronic otitis externa. So the patient's just going to manage this condition as best as they can, avoid water, avoid poking, prodding in the ear, which unfortunately the patient did do, which caused the impaction against the eardrum of the dry wax and dead skin. So I'm just mopping up near the entrance with a fine end. You see this very scaly, dry skin. And this is on the cartilaginous portion, the outer third. And now as we're peeling this layer of skin, it's approaching the bony part. So around the bony part again, we're just going to be very careful we don't make contact with the bony part of the ear canal. So there's just some dry skin posteriorly. Okay, most clinical ear care specialists would kind of normally advise us to leave this if possible, if they find it tricky to remove. It's, as I said, the procedure has been complete, but I generally like to remove as much dead skin as possible in cases of chronic otitis externa, and it's not possible to remove every little last flake of skin. You'll be here for hours doing that, and although it looks magnified with the iClearScope, in reality we're looking at less than 0.2 millimeters in some of these flakes. Are very, very minute. So we're on to the patients, same patients left in. Again, this dry skin around the perimeter of the soft wax and the core. It's embedded against the ear canal wall and the eardrum. And similarly to the right ear, the entrance of the ear canal in particular, there's a lot of dryness, a lot of eczema, psoriasis, and the patient has been scratching. You can visibly see the outer bowl of the ear canal when we come out. It's quite red, and you can see the marks, the sore marks where the patient's been scratching. So again, clinically the procedure's done. We can see the eardrum, the patient's hearing loss has been alleviated and rectified. So I would have no qualms with any of the specialists that we train with clear wax if at this point they stop the procedure, because this is a little bit more tricky and delicate when we're peeling dead skin and wax off the bony part, especially of the bony part of the ear canal wall. The patient would be able to hear equally as well now as they would after I peel all of the dead skin. But for me, I like to, as I said, remove as much dead skin, more of a preventative measure. Don't want this dead skin getting infected and then leading to otitis externa again, so an infection of the outer ear canal. And see just posteriorly at the back part, the bony part of the ear canal wall, I'm just quite stubborn piece of dead skin here, and just trying to get a suction grip and then lever away, retract, elevate it off the canal wall. With this eardrum, we can see the features. We can see the hammer bone, we can see the light reflex. The eardrum is probably not as translucent as an average, normal, healthy eardrum. Slightly more opaque, but nonetheless, we can see the features. Again, it's really delicate here. really want to avoid touching, making contact with the bony part of the ear canal. There is some here. I don't think I'm going to be able to get this because, well, I'll actually surprise myself there. Yeah, I'm pretty okay with that. So this is probably the juncture of the cartilaginous portion and the bony part. And you can see the skin just lifts up, just hovering over it, just the suction probe got blocked. So there's that dryness at the entrance. So again, we're using a fine end tip. So that flake of skin easily came off. So there's some dry skin at the top, the roof of the ear canal. Again, I'm not sure if I managed to remove all this, but you can see the eardrum in the distance. Some dry skin that we're peeling off the anterior canal wall, so the front part of the ear canal. There we are. So again, just at the roof of the ear canal. So if you're in the UK, guys, and you've got a blocked ear and you need to see someone to have your earwax removed, please do visit our website, www.clearwax.co.uk. The URL is on the top right side of the screen. You can enter your town, postcode, and you'll have your nearest Clearwax specialist appear, and you can click to view their specialist profile. You can learn about their opening and closing times. They'll each have a little bio, so you can read up about them, learn more about them, and they've got all their pricing there and the treatment techniques and methods that they offer. Hope you're enjoying your Saturday evening wherever you are in the world, and I shall upload some more videos in due course. Take care, guys. Bye.